Good afternoon, and welcome to the 544th in our series of distinguished speaker programs. I'm Barney Bishop, and I'm president of the Economic Club this year. If you have not done so yet, please be sure to visit the club's website, which has been redesigned last year as part of our rebranding initiative. You can find links to the club's YouTube page for video recordings. You can listen to past speaker programs on our podcast page, and you can find our upcoming speaker schedule as well. I'm going to tell you about our next two speakers so you can think about it and maybe get it on your calendar now. Our next scheduled program is going to be Thursday, May the 20th, when we welcome Juan Carrilla, who's the Port Director and CEO of Port Miami. This will be an in-person meeting, and we will be back at our usual meeting place at the FSU Alumni Center. By the way, the FSU Alumni Center will always be our default meeting location. But they had a conflict today, and so we're back here at the Governor's Club. And when there is a conflict in the future, we will be back here at the Governor's Club. So it's going to be one of those two places. Please be sure to check the club's website to stay up to date on our upcoming speaker program. The next one after that is going to be June 3rd, and it'll be a virtual meeting, so you won't be having to go anyplace. It'll be with Dr. Judy Monroe, and she is the President and Chief Executive Officer of the CDC Foundation. So be sure to go to our club website and register for that virtual meeting. I would now like to take a moment and thank our club's sustaining members. If you would please rise, who provide additional financial support to our club each year. Please be recognized. Thank you so much. Great, let's give them a round of applause. And now I'm going to introduce our distinguished speaker. Alan Levine is the Chairman, President, and Chief Executive Officer of Ballad Health, the 40th largest hospital system in America, based in Johnson City, Tennessee. Ballad Health is an integrated health system serving 29 counties. Let's see if I can get this correct. Alan, check me. Northeast Tennessee, Southwest Virginia, Northwest North Carolina, and Southeast Kentucky. And that's almost 1 million people that they serve in that part of Appalachia. The system is comprised of 21 hospitals, including 3 tertiary medical centers, a dedicated children's hospital, community hospitals, 3 critical access hospitals, a behavioral health hospital, an addiction treatment facility, long-term facilities, home care and hospice. I think you got me covered from birth to death there, Alan. Retail pharmacies, which I need more and more, by the way, and outpatient services, all operated by a comprehensive medical management corporation. Ballad Health has 14,000 employees, has an annual revenue last year of almost $2 billion. And I imagine that he's most proud that Forbes magazine recently named Ballad Health as the 29th most diverse employer in the entire country. Alan has had an envious career in healthcare, starting in Florida, where he was the CEO of the South Broward Hospital District. He then came to work in the executive office of then Governor Jeb Bush as the Deputy Chief of Staff, and then Governor Bush appointed him, and he was confirmed by the Florida Senate as the Secretary for the Agency for Healthcare Administration, which we all know as ACA, which oversees our state's Medicaid system. So just so you get this right, we have 3 former secretaries of ACA. We have Liz Dudak, we have Mary Mayhew, and we have Alan Levine. So that's quite a bit. If you imagine that each one of them, when they were the secretary, Medicaid took up about 1/3 of the state budget, whatever it was. Now it's about $32 billion. So not a small inconsequential number. He was then recruited after working for Governor Bush by Louisiana Governor Bobby Jindal and served as his Secretary of Health right after Hurricane Katrina hit New Orleans. So you can imagine what the job must have been like given those dire circumstances. He then left that job to go into the private sector and became Senior Vice President of Health Development, Operations and Government for HMA, a chain of hospitals in the southern United States, before being selected as President and Chief Executive Officer of Mountain States Health Alliance, which he has successfully integrated into what today is known as Ballad Health. He's got a ton of other Florida connections, and so Gators, get ready for this. He is a triple graduate of the University of Florida. He's got a bachelor's degree in health. He's got an MBA degree, and that wasn't enough, so he went and got another master's degree in health science. So Gators, go for it. He was recently appointed to his second term on the Florida Board of Governors, which oversees the state's university system, initially by Governor Rick Scott and again by Governor Ron DeSantis. And Alan, I think we'd all like to know how you work that out between those two governors. Maybe he'll tell us about it. It's my pleasure and honor to introduce, and let's give a warm Economic Club welcome to Alan Levine.
Well, first, I have to say one correction. I wasn't reappointed by Governor DeSantis. I did serve as Governor DeSantis's chair of his healthcare transition with the lieutenant governor, but both of my appointments were from the previous governor. But it's an honor to serve on the Board of Governors and to be back here in Florida, to see so many friends. I definitely want to give a shout out to Liz Dudek. I was a little assistant administrator of a hospital in 1992. And I had to make a run up to Tallahassee because we were applying for a certificate of need. And I had to go meet with this lady whose name showed up on all the certificates of need. And I was a little nervous and intimidated. And I came up and met with her, and she made it such an easy process. Little did I know, eventually I would be the secretary of that agency, and she and I would be working together, managing Florida through 10 major hurricanes and Medicaid reform and a lot of things that we did together. And I'll talk a little bit more about some of that. Dave, Mike, it's great to see you. It's just great to see some old friends. Barney, thank you for inviting us back. And Cindy O'Connell, I've admired you since I was a student at the University of Florida. Anyway, but let me tell you a little bit quickly about what I plan to do today is tell you a little bit about Ballad Health, who we are, what we're doing, because I'll come back to it at the end, and you'll understand better why we are doing what we're doing based on the dynamics of the healthcare marketplace. And then I'm going to talk a little bit about the pandemic, how we dealt with it, what we think the world is going to look like coming out of the pandemic, and then, of course, what I think some of the future challenges for healthcare are. Mary, I don't think any of this will be a surprise to you since you're in the trenches all the time, and you did a great job as secretary as well, by the way. It's an honor to be here with you. Ballad Health was created, we were two competing healthcare systems in a region the size of New Hampshire with a combined 21 hospitals that it was almost an irrational level of competition. Two level 1 trauma centers within 20 miles of each other. Here you sit in Tallahassee, the closest level 1 trauma centers in Gainesville. And that's by design, that's on purpose. That's the way a trauma system is supposed to work. But 2 level 1 trauma centers, 2 level 3 NICUs, a lot of unnecessary redundancy that was diluting patient volumes, costing a lot of money. And it was the health system working exactly as it was designed. We're a fee-for-service system of healthcare where the more work you do, the more you get paid, the more things you do, the better off you are economically. But what we saw in 2014 was that the world was changing. The entire payment system was changing, and all of this redundancy would have led to these two health systems being sold or being acquired by other large health systems. And what's happening throughout the country right now is these large hospital systems are getting bigger through consolidation. What they're doing is they're leveraging their size to increase their pricing. And unfortunately, that's happening because insurance companies have gotten so big. So all this consolidation and leveraging is happening. And who's getting stuck in the middle of all this are the patients and the employers who are paying for this and the taxpayers who are paying for it. So we decided we wanted to do something a little different. Now I'm going to come back to this in a little while after I walk you through what I see as some of the challenges and give you a better picture of what we're trying to do as Ballad Health and why we think what we're doing is a pretty good model for a large rural system. Let me tell you first, before the pandemic hit, there were serious problems in our health system, led by the nursing shortage. Before the pandemic even occurred, the United States was facing the worst nursing shortage in history. 176,000 nursing openings per year between 2019 and 2030. 176,000 openings. More than 1 million nurses were projected to leave nursing. The average age of a nurse was 50 years old. This was in 2019, before the pandemic. So we came into the pandemic with a massive shortage that was creating access problems and driving up the cost of healthcare. Number two, the issue of social determinants of health. You will hear a lot more about this. You know, that you hear a lot about equity in healthcare, and equity in healthcare is the underpinnings for the equity issues in healthcare really come back to the issues of poverty. No different than anything else. In a rural area like where I serve, we have significant equity issues of people that live in rural communities that don't have access to care, where you have a lot of other social determinant issues, low income, poor outcomes in education. One of the worst contributors to social determinants and poverty is education. And I said education twice for a reason. This is a big reason why Ballad Health exists. And again, I'm going to come back to that. But social determinants were a big issue prior to the pandemic, accentuated by the pandemic. Third, rural hospital closures. More than 150 rural hospitals in the United States have closed since 2010, and almost 600 more are in financial jeopardy prior to the pandemic. And again, this is all was happening before we got hit by this generational issue with the pandemic. The aging of our population, you know, more than 80 million Americans are projected to be over the age of 65 in the next few years. This aging of the population combined with a worsening chronicity of the population, more diabetes, more cardiovascular disease, more mental illness. A lot of these things that contribute to poor health begin to manifest themselves into healthcare costs as people age. And the shifting and changing of payment models, I'll talk more about this. Insurance companies, Medicare, Medicaid, all of these payment models were changing in a way that fundamentally changed the business model for a hospital and for the health delivery system. So all of these things were occurring even before. And then you overlay on top of that billions of dollars of private equity that's been sitting on the sidelines looking for ways to disrupt the healthcare system. And you know, that's, again, I'll talk about that in a moment, but things like artificial intelligence, machine learning, is going to change dramatically how the healthcare is delivered in the country. And the pandemic accelerated this. And again, I'll address that. But this is what we brought into the pandemic. Now, I will tell you, I used to have a friend in New York City, and every day, Liza, you've probably heard me tell this story, so you know the punchline, but every day, my friend would go downstairs from his building and he'd put a quarter on the newsstand, but he would never take a newspaper. And he did this every day for about a year. Every day, go downstairs, quarter on the newsstand, would walk away, never take a newspaper. And finally, one day, the owner of the newsstand saw him coming and said, "Sir, I need to talk to you." And my friend said, "I know, you want to know why I put a quarter on the newsstand, but I never take a newspaper." And the owner of the newsstand said, "No, I don't care about that. I just want to let you know the price went up to 50 cents 2 months ago." But that's what we deal with in healthcare. People expect high quality, they expect good outcomes, but when it comes time to pay the bill, it's a shock. And the system is getting more expensive, and dramatic things need to occur if we're going to change that cost curve. Again, back to why Ballad Health was formed, and I'll share some more of that with you. But then the pandemic hits. Now, I'm going to tell a story that I know Liz will understand. Back in 2004, I had just been named Secretary of ACA. And a month after I was named Secretary of ACA, this little hurricane called Hurricane Charlie was making its way up the west coast of Florida. And I remember I was sitting with Governor Bush. We were sitting in the Emergency Operations Center. We had planned for that hurricane. We thought it was going to go up into Tampa Bay. And Ben Nelson, who was a state meteorologist, came walking into the EOC. He looked a little frazzled. He said, "Governor, the hurricane's changed. It's turned and it's moving inland." The governor said, "Well, where's it going to hit?" He said, "Port Charlotte." Governor said, "When?" He goes, "It's hitting right now." So we assembled a press conference immediately and we warned everybody. But Liz will remember, during that hurricane, now, you know, emergency operations centers are structured so that it's a local response, And then if they can't deal with the issue, they put it in the system. It comes up to the state EOC. If we can't deal with it at the state level, we put it in the system, and then FEMA takes care of it. Well, we're sitting here. We know the hurricane's hitting. We know there's hospitals in Port Charlotte whose roofs have been blown off that had 200-300 patients in those hospitals. So we sat there and said, well, we can't wait for them to ask for help. We know they're going to need help. So immediately, we established a call center, and we started calling every hospital and nursing home in the state twice a day, so we could lay eyes on how much fuel they had, how much water, how much food, whether or not they would need assistance with evacuations. And this dramatically changed. That was the first hurricane. By the third hurricane, we had done it on the web and automated it, and now that system is being used by every state in the country. It's called ESS. You know, we realized when you have a disaster brewing, you can't wait for a problem to show up. You have to be like a guided missile looking for problems to solve. And that was a culture that was established by Governor Bush at the time. And it was something that we established at ACA. And little did we know we were going to have 3 more hurricanes that season and then 5 more the next season, all of which at some point the entire state of Florida was either preparing for a hurricane or responding to one all at the same time. And so the reason I tell you that story, some of this stuff follows me because we had all those hurricanes. I left and went to Louisiana, and then we had hurricanes Gustav and Ike. Then we had the pandemic, H1N1. Then we had Deepwater Horizon oil spill. I finally gave up and said, I think maybe I should get out of public service because this stuff keeps following me everywhere I go. But what I learned is when you're heading into something like a global pandemic, it doesn't matter what your plans say. You could draw plans up, but I assure you those plans will fail. And so what I told my team when we started dealing with this pandemic back in February a year ago, I told them, read the plan, understand the plan. We formed an emergency operations center, and I said, your job is to go look for problems to solve. Whether they're ours or someone else's, lean in. We started having daily press briefings, which became a mainstay. We became a source of truth for our region. In an era of social media and misinformation, the public just wanted to know what was going on. We were honest. We told them that we were short of nurses, and we started consolidating our facilities so that we had the nurses able to care for COVID patients. Supply chain, we formed a logistics team. We never had a problem with PPE because we knew that was going to become a problem. Back to look for problems to solve. And so we put a guy in charge of our supply chain who is a former Marine, I guess once a Marine, always a Marine, thankfully. And he did a great job managing our supply chain, so we never ran out of PPE. I mentioned consolidation of staffing, deferral of cases of elective surgeries and procedures. All these things we had to do because we were looking at the availability of nursing staff, and we knew if we didn't defer elective procedures, our nurses would get overwhelmed. And the worst thing that could happen would be to have our nurses and doctors get overwhelmed because they'd burn out and they wouldn't show up. And so back when they did the enhanced unemployment benefits, we took advantage of that as an employer where when they did the enhanced unemployment benefits, we identified about 1,400 of our team members that at the time would have been better off being furloughed and taking advantage of the unemployment benefit. That was a benefit to us because we could reduce our cost structure at a time all of our elective business was gone. At the same time, they wouldn't be harmed economically. Now, of course, that circled back around, and this issue with enhanced unemployment benefits is having the opposite effect, which thankfully governors are starting to address in a different way. The other thing that we leaned into was the use of telemedicine. My biggest concern during the pandemic has been the number of people who have either had an acute situation and didn't go to the emergency department, or who have chronic conditions and weren't getting ongoing care, or who were not getting their preventive testing done. So the first category, people that, the number of chest pain ambulance visits to our emergency departments dropped by 50% during the pandemic. Now, I'm not convinced that there were 50% fewer chest pains. I'm convinced that people were having chest pain and didn't call for help because they were afraid to come to the hospital. And I think that's going to result in a lot of issues in the aftermath of the pandemic. cancer patients who weren't being able to access their treatments, patients who were not going and getting their routine preventive screenings, who are going to find later that they missed something because they didn't get those screenings. Those things are all mounting challenges that I think are forthcoming for the healthcare system. But telemedicine was one of the areas that, from July of 19 through the beginning of March of 2020, Ballard Health did 2,400 telemedicine visits. April and May of 2020, we did over 15,000. So we ramped up telemedicine in a period of weeks. And part of the reason we were able to do that is the federal government changed the payment policies so that, and this helped doctors, this helped hospitals be able to maintain access for their patients so that they could at least see their doctor or go to an urgent care online through telemedicine. And so annualized, we're now doing 80,000+ telemedicine visits a year, and I don't think that goes away. I think that's, particularly with all the investments in technology, the use of telemedicine connected to artificial intelligence is going to transform how healthcare is delivered. Again, I'll talk about that in a minute. The biggest problem I found during the pandemic was misinformation. In my region, we were working really hard to make sure people got good information. We wanted them to understand what they could do to protect themselves and their families. There was one point where we had a morgue truck in front of one of our hospitals. We had to use a morgue truck because our morgue was full. Our region had over 100,000 COVID cases, over 2,000 deaths in our little region alone. And we could not necessarily convince everybody that this was real. And so when we parked the morgue trucks in front of our hospitals, it was out of necessity. People thought we were making that up just to scare the public. And it was concerning because people really were dying. People were coming to the hospital and they were being diagnosed with COVID, but they didn't believe it when we told them they had COVID. And that was probably the worst for our team, particularly our nurses. So what we did is we started an ad campaign. We just got our nurses and we put them on camera and said, tell your story. And our nurses started saying, this is what we're dealing with. I had to put 4 patients in a body bag in the last 3 days. I'd never done that before. Please take this seriously. And it worked. Nursing is the most trusted profession, bar none. Whoever's number 2 is a distant number 2. And it's certainly not hospital administrators, I can tell you that. But I'll tell you, those nurses had an impact. People started listening. People were wearing their masks. People were doing social distancing. And, so it actually helped us stabilize and start bringing the rates down. Well, the other thing that happened was I give credit to the Trump administration when they leaned in very heavily at the very beginning. They pushed a lot of money out to hospitals and providers through a bunch of different mechanisms. The provider relief fund, almost $200 billion was distributed to hospitals. Now, there's a lot of questions about how that was done and whether that went to the right hospitals. But the reality is that really saved the bacon for a lot of hospitals, particularly hospitals that were teetering even before the pandemic. They did accelerated payments, Medicare advanced payments to hospitals, which hospitals do have to pay back. And that's going to be a lingering issue for hospitals going forward. Clearly, they want to pay it back, but also we're still dealing with it. Today, we have probably over 100 COVID patients still in the hospital. It's not gone. It's not going away. And frankly, what we're seeing in India now is really troubling. They now have a triple variant in India, and there's questions about whether the vaccines will be effective with the triple variant. So, this is not over. And it's easy we all want to get back to normal as fast as possible, for sure, including myself. But we're watching this thing because it is not over, and if we've just got to stay diligent. But these are things that the federal government did that did keep the healthcare system stabilized while we were going through this. And I do give Seema Verma, who at the time was the administrator of the Federal Center for Medicare and Medicaid Services, I give her credit because she understood early on that we really did need to stabilize these hospitals, which were the cornerstone of the response to the pandemic. So what happens now that the pandemic has hit us and we've dealt with the sort of critical mass of it, where do we go from here? What does the health system look like? Well, first of all, I think what we're going to face with nursing is massive PTSD. I think that you've got nurses who for a year would go to work, have to change their entire PPE every time they go into a different patient room. And if you've never seen what they have to wear, it's intense. It's these masks, it's all the gowning and everything else. You go into one room, you have to change to go into another room. And you're doing this all day. And you're dealing with patients who are very sick. Now, if you haven't, I have seen a COVID patient. I've seen a COVID patient who was 50 years old, who was literally fighting to breathe. And again, I'm going to mention this in a minute, but these patients suffer, and they fight to die. It's the worst thing I'd seen. And these nurses, from an emotional standpoint, they dealt with that, and then they go home, and they had to go home, and they had to protect their own family, and then they had to come back the next day to do it all over again. And the fact that they kept coming back during the pandemic, we gave our nurses a 15% pay raise, and we did a lot of other things. In 30 years, I've never seen a health system give a 15% pay raise across the board to their nursing staff. But we knew we had to do something. It wasn't enough. I mean, clearly, how much is enough to tell these nurses how much you appreciate them? And we're right in the middle of nursing week right now, so we do appreciate our nurses. But whatever steps hospitals can take to stabilize the nursing workforce, they need to do it, and they are doing it. This is going to add a lot of cost to the system, and it's real. But I will tell you, and I mentioned the statistics earlier, and it bears repeating, 176,000 openings for nurses each year between now and 2030. The worst part of the shortage is going to hit the South and the Southeast. And it's being, as good as it is to see the economic growth in the Southeast, that's actually going to compound it. As more people move to Florida, to Tennessee, to Arizona, to southern states, these states are going to be hit really hard by this shortage, particularly if people are nearing retirement. Nursing school enrollment is not growing fast enough. And as a member of the Board of Governors, this was a topic on our agenda yesterday during our call. We had an hour-long panel to talk about healthcare manpower shortages and what higher education needs to do. This is a big deal. In 2019, 81,000 applicants for nursing school were turned away because there's not enough faculty. That's national data, not Florida, by the way. But that because there's not enough faculty, there's not enough clinical rotations. And this is something that's got to get the attention of higher education. I chair the Research and Academic Excellence Committee of the Board of Governors. I assure you it is on our agenda, and it's something that we're going to be leaning heavily into. Florida has the #1 2+2 program in the United States, the state college to university transfer programs. It's the envy of the country, and I can assure you of that. We've got to find a way to take more advantage of 2+2 to make sure that the state colleges, and this is where there's a mismatch, and what I'm going to say is a little bit controversial, and I don't mean to be controversial, I'm just calling it as I see it. For too long, the professions which are driven by their licensed professions, and we all know what it looks like in the legislature, Dave, you know what it is in the legislative process. There's always a food fight between the doctors and the nurses and the different professions as they all try to expand and grow their own profession, which is understandable. But what happens is as more and more of these professions go back and say, well, we need more doctorate of nursing practice degrees. We need more advanced nursing degrees. When you're running a health system, we don't need more of those. We need more nurses who want to be bedside nurses. And so if you're training, well, I'm making up numbers now, but if you're training 100,000 nurses and only 70,000 of them are going to go into bedside nursing, the data's wrong. It's skewed. All those shortages, the numbers I just gave you, those numbers are skewed because they're including those advanced nurses in the numbers. So the shortage is worse than what I'm saying. And so my pledge as a member of the Board of Governors, this is something I plan to be pretty loud about here and in the state that I reside in now, which is Tennessee, because if we don't get ahead of this now, when I mentioned earlier, the average age of a nurse today is 50. When I was Secretary of Healthcare Administration, the average age was about 40. So what's happening is Our more experienced nurses are retiring. The pandemic, as I mentioned, the issues with PTSD, you know, I liken nurses during a pandemic to people in the military during a time of active war. When you're in the trenches, if you're in the military, you don't abandon your fellow troops. You're right there with them. Well, during a pandemic, our nurses would not abandon each other. They were right there by each other's sides, fighting tooth and nail for their patients. But as things start to pull back and get more into a normal mode, all of a sudden, the emotional effect of that's going to hit our nursing, or it's going to hit nurses. And I think nurses who are within 5 years of retirement are going to accelerate their plans. And I think it's going to accelerate our shortage. And so we've got to do something. And I think looking to the state college system and looking at our universities and saying, look, we got to start pushing back on some of these advanced degrees and start pushing to open up the doors to more of these folks who have the capacity to be a nurse or a physical therapist or a respiratory therapist. It's not just nursing, it's across the board. Nursing, respiratory therapy, medical technology, physical therapy, physicians, primary care, all of these shortage areas are going to manifest themselves into access problems. And I mentioned equity at the beginning. The people that get hurt the most when this happens are people in rural communities and people in minority communities where it's difficult to get and to recruit and retain healthcare talent. And so I think these are going to be, I think nursing is one of the biggest long-term issues. The next issue that I'm concerned about is long haul. There's a study that just came out of the University of California and several other places. 25 to 35% of people that have had COVID are demonstrating long haul symptoms. Now, these are people, by the way, that did not get hospitalized. These are younger people who hardly had any symptoms while they had COVID. Now they're starting to show long haul symptoms, loss of memory, fatigue, extreme fatigue. People who would exercise before, now they can't even walk their dog without having to stop to catch their breath. Chest pain, shortness of breath, abdominal pain. I mentioned brain fog, depression. It's multisystemic and it's unpredictable. We formed a long haul clinic that you can access using virtual technology. Even people here could call Ballad and get into our virtual clinic. We just deployed a $200 million common technology platform. We're working with that technology vendor to collect the data so that we can share with other health systems and learn what are the main symptoms people are seeing and what is working to help treat these symptoms. This is where artificial intelligence is making a difference. Because if we were doing this the old way, it would take us 15 years to figure this out. But the ability to collect the data, learn from what everybody else is doing, disperse that information quickly so that we can provide treatment, it's going to help. But long haul is a real thing. And so I think this is something physicians are going to struggle with when they have patients who come with these symptoms, they don't quite know how to deal with it. And in a fragmented health delivery system, you know, all of a sudden, now you're referring a patient that has a shortness of breath, maybe you're going to refer the patient to a pulmonologist. Or maybe you're going to refer a patient over to a rheumatologist, depending on their symptoms. That's why we formed a long haul clinic. It's multidisciplinary with multiple types of physicians collaborating. So if a patient comes in with multiple symptoms, there's multiple physicians who are having a conversation about that patient's needs so that they can come up with a plan so the patient's not having to run around in a fragmented system. This is new, we're learning, but that's the issue that we're facing. Catch-up symptoms, ER visits, I mentioned, dropped precipitously. I think we're going to see a spike in cancer diagnoses and other types of things that people had foregone during pandemic. I think it's going to show up at our doorsteps now, and it's going to be more acute and ultimately, unfortunately, more chronic. And so this is something that we're obviously preparing for. And I mentioned, I'm going to get away a little bit from the pandemic and talk about all those challenges I mentioned that were facing hospitals before. Let me revisit some of those now. Artificial intelligence and the billions of dollars of destructive capital. And destructive is not a negative word. I mean, destruction is how you improve and how you grow. It's what we did in our market when we formed Ballad. We destroyed the existing model and said we need to do something different. Well, there's a lot of equity capital out there. And if you look at what's happening, ShareCare, for example, is a technology that's out there. It was founded by Jeff Arnold, who founded WebMD. They're going public in a $4 billion offering right now. We happen to be partners with Sharecare, but the engine behind Sharecare is now with the technology of your iPhone, you have enough bandwidth. You don't have to keep your health data in a cloud somewhere. It can reside right in your phone and you can own it. And that's where this is going. Imagine a situation where you're sitting there at work or playing golf and all of a sudden your phone vibrates and says, your heart rhythm is off. You're gonna have a heart attack. Click this button and you can talk to your doctor immediately. That's coming. And that's what the private equity investment, that's the combination of equity and technology, and that's going to be very destructive to the existing health system. Healthcare at home is coming. You know, there's a day coming in the next decade where most hospitalizations won't be in the hospital. They'll be at home, where the only people in the hospital are people who have surgery or who have a serious medical condition where the hospital is the only safe place they can be. This is transformative, which is why two competing health systems like Wellmont and Mountain States were up in our region, trying to maintain all that fixed cost was unsustainable. And coming up with a different model was critically important. And again, I'm about to come to that. Payer system changes is like pouring fuel on this fire. In the old days, you got sick, you went to the hospital, your insurance company paid for it. Now the insurance companies, they go to these large private primary care groups and they say, here's your patient population. If we collect $1 in premium, if the healthcare spending for your population is below 85% of that premium, you get to keep everything below the 85%. You talk about changing the economic incentives in the health system. In my region, before we formed, 3 years ago when Ballad formed, we were doing 100,000 discharges per year. We now have dropped our volumes by 16,000 per year, because we saw that coming and we started entering into those contracts where we began destructing our own volume. And it cost us $200 million a year in revenue. But let me tell you how that translates. If we're out there managing lower acuity patients outside the hospital and avoiding lower acuity admissions, and we're reducing our revenue by $200 million in the process, that meant the cost of healthcare for our community dropped by $200 million. The mayor of Washington County, Tennessee, wrote a letter saying, for the first time that I can remember, our health insurance premiums have actually gone down. And it's because of what Ballad Health is doing to reduce the unnecessary inpatient hospital utilization. Now, a state like Florida, where you have massive growth of population, you can have decreasing inpatient use rates and hospitals can still thrive in that environment. But if you go to rural and non-urban America where this is happening, this is why you see 150 rural hospitals closing and why 600 more are in financial jeopardy. And it's why non-urban hospitals are being sold and joining larger systems, because they can't survive in this environment where they're losing that volume and they don't have anywhere to offset it. So I think all of these changes, and I'll tell you, Barney mentioned Medicaid. Medicaid's important for two reasons. Number one, there's no bigger frustration to a governor and a legislature than the cost of Medicaid. If you remember in 2005, when I was secretary, I still have the arrows in my back, when we did the Medicaid reform in 2005. At the time, it was the most sweeping reform of Medicaid in the history of the whole program, where we moved the entire Medicaid population towards a managed approach, prepaid networks, better aggressive management of patient care to avoid higher cost care. At the time when we did that, the Medicaid budget was $14 billion. Now you're knocking on 30 billion. That's with the reforms we did. So on the one hand, there's nothing more frustrating to a governor and a legislature than wanting to invest in education and wanting to invest in roads and infrastructure, but having those dollars get diverted into Medicaid. On the other hand, there's no better tool that a state has to help transform the issue of social determinants and equity than the Medicaid program. The ability to use, you're the largest purchaser of healthcare in the state outside of Medicare. You have $30 billion a year that the state is spending. What better way than to work with hospital systems, integrated delivery systems, to say, how do we identify people that have issues of social determinants? How do we get in front of this? Well, let me tell you about Ballad. This brings me back to Ballad Health, and I want to stop for a minute and give Speaker Chris Sprouse enormous credit. In Florida, I don't know if you know this, in Florida this year, and our governor in Tennessee did the same thing, they extended Medicaid eligibility for women who are postpartum from 60 days to 1 year. Let me tell you why that's important. I'm going to come back to the Ballad Health story. So is it more important to have 2 level 1 trauma centers, 2 level 3 NICUs, and a bunch of redundancy that costs tens of millions of dollars a year? Or is it better to say, we're going to transform the delivery model and say, okay, the larger problem for our economic system is in our region, before the pandemic, our unemployment rate was only 3.5%. So you'd say that's great, except that our workforce participation rate was horrible. It was we had about 50,000 people out of the workforce above what the workforce participation rate was expected to be. Why was that? Social determinants, people living in poverty, people in the coal mining industry that lost their jobs and never found another alternative, people with behavioral health and addiction issues, all of these social determinant issues that feed into people having chronic conditions. 800 kids in the foster care system. I mean, all of this is a manifestation of poverty, and poverty is what drives issues with equity. And so we said, what is our role as a health system in helping to correct this? We don't just want to sit there and wait for people to show up at our doorstep sick and say, okay, now pay us because we're treating the symptom of the problem. How do we help actually solve the problem? So, what we figured was if you want to reduce improve the workforce participation rate, make sure your 18-year-olds can graduate college or career ready, right? Seems like a reasonable goal. Well, what's the biggest predictor of people graduating college or career ready? Third grade reading. Third grade reading. You are 4 times more likely to graduate college or career ready if you can read at the 3rd grade level. Now, a state like Tennessee that's out there competing to bring new manufacturing and new jobs, you can't bring new manufacturing, new jobs if you don't have an able workforce. And so this is a really important issue for economic growth. It's important for Florida. When you get to full employment, the next place to look is the people that are out of the workforce that you want to bring back in. And you have to understand the root cause for why they're out of the workforce to begin with, and give them the economic opportunity to be able to be self-sustaining. Well, 3rd grade reading is a pretty good indicator. What's a good indicator of 3rd grade reading success? Kindergarten readiness. Now you're getting into Ballad Health territory, because as a single system serving a region the size of New Hampshire, and I have to tell you, I'm going to stop and tell you how this happened. We had to go to the state of Virginia, to the legislature in Virginia, and we had to go to the legislature in Tennessee. We had to convince them to pass special legislation creating an exemption from federal antitrust. Then I had to get a Democrat governor in Virginia and a Republican governor in Tennessee to sign that legislation. Then I had to get 2 attorneys general, one a Democrat, one a Republican, to not oppose the legislation, all with the fierce opposition of the Federal Trade Commission. We did it almost unanimously in both houses of both states legislatures, in the Senate and House in both states. Both governors signed on. The health commissioner said, we agree with what you're trying to do, and they signed what's called a certificate of public advantage, where they said, Ballard, go forth and do this. Now, back to the commentary about education and kids that are wanting to get kids to kindergarten, ready for kindergarten, because we know that ultimately leads to 18-year-olds graduating college or career ready. Number one, this requires patience. Everybody wants a silver bullet to solve these problems. There are no silver bullets. It requires a committed effort to identify the root cause of a problem and try to go to the root cause and stick with a plan and stay on plan. And believe me when I tell you, I'll tell you the story about this kid that wanted to go do battle for his king. And he said, King, I'm ready to go do battle. And the king said, son, I'm sorry, you're just not ready. You're too young, you're inexperienced, you're going to get killed out there. And the kid said, no, King, I'm sorry, but I believe in you and I'm going to fight for you. And the king said, all right, gave him a sword, a shining armor, and a horse, and sent the kid on his way. About 2 months later, the kid comes back. He's limping, the sword's broken, the horse is all beaten up. And the kid says, King, I have defeated our enemies to the east. And the king looked at the kid and said, son, we don't have any enemies to the east. And the kid looked at the king and said, well, sir, we do now. And when you're out there saying, this is what's coming, and we want to change to something so dramatically different that no one can quite understand it, you're going to get beaten up. And for the last 3 years, we've gotten beaten up as we've made a lot of these difficult changes. But here's what we just rolled out. I'm going to land here and happy to answer any questions if there's time permitting. But so here in a community where you had 2 hospitals, both at 30% occupancy, both of them had lost close to $70 million in the 5 years leading up to our merger. Well, when we merged and created Ballad, we consolidated those 2 hospitals. So now we have 1 hospital in that community that's more sustainable. We've reversed those losses. We've converted the other hospital to a residential facility for women who are pregnant, who suffer from homelessness or drug addiction or alcoholism. Now imagine that. Instead of a woman having to deal all alone with addiction, alcoholism, homelessness, or whatever else contributes to those social determinants, which most assuredly is going to result in a child that's born into a situation where they can't thrive, never mind kindergarten readiness, they'll probably end up in foster care. Let's give the woman a place to live that's safe. Let's provide food security. Then let's wrap those services around the woman. This is why what Speaker Sprouse did was so important. A health system like Ballad that understands how to create a business model around a sustainable business model. What Governor Lee did in Tennessee, and what you guys and Governor DeSantis and Speaker Sprouse and President Simpson did here, created the opportunity to put a business model together that's sustainable. So what we've created, we call it Strong Futures. These women hopefully they'll get workforce training, they'll get literacy training if they can't read, they'll be given parenting skills, they'll have food security, they'll get addiction treatment, alcohol treatment if they need it, right there in a safe place. Now imagine, I think that's a better model than 2 hospitals trying to replicate each other, putting each other out of business. Now that's what we're doing. The next thing we've announced called Strong Starts. We deliver almost 6,000 babies in the region. Every single woman that's pregnant will be assessed by their physician. And again, using artificial intelligence and using the data systems that we have, we can then identify those women who are very likely to face the risk of adverse childhood experiences for the child. So that we have formed the largest accountable care community in the country. We have more than 300 businesses, schools, government entities, law enforcement collaborating with us, so that when we identify a woman that has certain needs based on these assessments, we can then plug them into a community-based organization that can help that woman with whatever those needs are, so their child is born into a situation where they're on a trajectory for kindergarten readiness. We're very focused on this. And to me, that is a good business model for a health delivery system that's in a region serving an underserved population. This is how we can create equity in healthcare, and hopefully the people that enter into these models that we're creating in 18 years, those kids will be graduating either college ready or career ready and be able to economically sustain themselves. And to me, that's how you fundamentally change the trajectory for our country. It's not, I don't think, blaming. I think we are where we are, and it's instead of trying to find blame, I think we as a health delivery system have an obligation to figure out what is our role in trying to solve this problem. If all we are is an entity looking for a profit, we're not doing our part in the social good. And I'm not suggesting profits are bad. You need profits in healthcare to be able to recapitalize, but you've got to look for ways to help solve these problems. So I'll conclude there and say I think Ballad Health. A lot of people had their doubts. 3 years in, let me tell you the result. Moody's, Standard & Poor's, and Fitch, all 3 credit rating agencies have upgraded Ballad Health to A ratings. Neither legacy health system had ever had an A rating. The year before we created Ballad, we had no operating income. I mentioned that we lost $200 million a year in revenue. After we merged and did all the things that we needed to do to eliminate the redundancies and get the synergies that we needed to get, and by the way, we agreed to cap our reimbursement. So our reimbursement, we actually cut our pricing for physician services and urgent care. Our pricing is actually lower now for most of these services where people get access to healthcare, and our hospital pricing is lower than our peers. So we agreed to cap our reimbursement. For us, this was not about trying to go back to insurance companies and get more money. We found another way to benefit from this financially, and that is eliminate waste, eliminate redundancy, eliminate unnecessary utilization. We've lost $200 million a year in revenue, and we went from 0 operating margin to 40 million positive. Our operating margin actually improved, even though we lost 200 million in annual revenue. And so we were upgraded by all 3 rating agencies, which is, by the way, during the pandemic. There were only 5 upgrades by Moody's, more than 5 times the number of downgrades. But we were upgraded at a time when I think we faced a lot of challenges. The monitors who overlook us, because we are under state action immunity from federal antitrust, the monitors have now come out with reports, and both states have come out with reports that said that the evidence shows that there's a public benefit to what Ballad's doing. And frankly, without Ballad, several more rural hospitals would have been closed. In fact, the 2 newest rural hospitals in the United States were constructed by Ballad Health. We opened a new hospital in one county 3 years ago, and we're about to reopen a previously closed hospital in Lee County, Southwest Virginia, far Southwest Virginia. So we're bucking all these trends because we thought about doing it differently. I'm not saying it'll work everywhere, but this is what leaders in healthcare have to do. They have to start asking themselves 2 questions. Number one, how do we contribute to the larger social issues that we're facing as a country? If we don't ask that question, what value do we have? If all we're doing is showing up for the purpose of billing and collecting, that's not a model that's sustainable, nor should it be. And frankly, I don't know any hospital administrator in Florida that does think that way. I think they are all struggling to find ways to help solve some of Florida's biggest problems. And I would encourage you to engage with healthcare leaders on this issue. And I'll end there, and Barney, happy to answer any questions. I think I don't know if I'm ahead or behind, but thank you.
Thank you, Alan. Now you know why he is perceived as a visionary leader in healthcare around the country. If you have a question and you'd like to come up, we have a couple of minutes for questions while we're waiting for the first one. Christopher, come on up. Let me ask a question, Alan, and that is, so you're in 4 different states. You've got Democratic and Republican governors. You had to survive the COVID pandemic. How the hell did you do that? Because every one of them's got a different idea of how to do business.
Well, that was actually a challenge for us, because in our region, we have the State Department of Health in Tennessee, and we have what's called a metropolitan in one part of our region, which is a totally separate health department. And then there's several health departments in Southwest Virginia, which is why early on we decided to lean in and become sort of a public source of truth. We had calls several times a week. Our command center, the leader of our command center, Eric Deaton, who is my chief operating officer, did a fantastic job getting in front of the cameras, being transparent about what we're seeing, what we're experiencing. And I will tell you, one Republican governor, one Democrat governor, both have been publicly very complimentary of how we manage this. Both have, they both have helped us in different ways. And I commend Governor Lee and Governor Northam. I think they both have done a very good job of working with us. I was on the phone constantly with the Secretary of Health and Commissioner of Health in Tennessee and the Secretary in Virginia. And that's how we did it. I mean, I've been through it so many times. I mean, 10 hurricanes in Florida, the pandemic in 2010, the oil spill, the Deepwater Horizon. So I've sort of, to some degree, when you've been through it, you sort of know what to expect. And what I've learned is nothing surprises you during a disaster. You just know whatever you think is going to happen, something else is going to happen. And you just have to be prepared for that. And I'd seen Melissa Stone here. Melissa was right by my side in Louisiana with Governor Jindal during the 2 hurricanes, Deepwater Horizon, the oil spill in the Mississippi, and the pandemic. So she knows what I'm talking about. Yes, sir.
Yes, excellent presentation. As you take it to the next step that you've talked about, the AI, the amount of capital sitting on the sideline, all the different technology that is all the ability to test the patient in the home, and then you begin to look at the AI doing the diagnostics, the whole next yard. How do you then factor in that this technology and ability will move that service, as in the high-tech industry, offshore? And how will it change the very essence of what you've built in your system?
Well, that's a great question. And to be honest, I don't really know the answer. I think we're so early in that process. It's certainly not unreasonable to assume that if there are ways to get labor less expensively, back office labor, that might be an issue. One issue we're facing now, even before we deal with that, is with everybody working from home. I mean, there's a lot of caregivers in a hospital, but there's an awful lot of support staff behind them that you don't see. And a lot of them have been working from home for so long. And I think you're going to find, I was just talking to, I'm on the board of a company, and one of my colleagues on the board is the CFO of a device company that's in the technology space. He said, you know, the problem they have now, and he's in California, tried to tell him to come east, still working on him, but he said the problem they have is, you know, they want their team members to come back, but their competitors, you know, the team members don't want to come back. They want to work from home, and the competitors are willing to let them do it. And so right now the question is, I mean, as a health system, we own an awful lot of real estate. And what do we do when we realize, okay, some of these people can work from home and the fixed cost that comes along with all that? But I think you're right. But I think the market's going to figure that out. I really do. I think the artificial intelligence, mechanical learning, it's creating new jobs and new opportunities now. And I think the market will figure that out. But I think the United States is poised to be very competitive in that space. So we'll see. I'm not an expert in that by any stretch.
So go ahead,
Okay.
Marshall.
And thanks again for the presentation. Wonderful. I'm sure you've done an exit interview on this whole COVID-19 for your whole system. What are the three things that you've done the best? And what are the three areas that you see clogged up? I mean, was it processing? Was it reimbursement? I mean, what are the walkaways? What's your exit interview?
I think the three things that we did the best were, number one, we leaned in from the very beginning. As I mentioned, we were like a guided missile looking for problems to solve. And I think that prevented a lot of things from becoming big problems. And that really, I've never seen a team come together so much as our emergency operations center did. No matter what part of the system they came from, they were in that EOC working day and night, looking for problems, coming up with solutions, communicating with physicians. You turn on the TV or you look at social media and you see somebody say, ivermectin, everybody should take ivermectin if they have it. Well, no, that could actually cause harm. And doctors were out there not knowing what to do. So we were trying to be a source of truth. So we had a science team that was dispersing information. So I think that's what the most important thing we did. Second, I think communicating with our community, because people just didn't know what to believe. And I think just being a consistent source of truth was important as a health system. I think if we can't do that, then we probably can't do much of anything. And I think the third thing is we tried to, early on, we decided we weren't going to make decisions based on the financial implications of those decisions. We knew when we stopped doing elective procedures, and we did it twice, in the spring and then again in the fall. But we knew it was going to cost us an awful lot of money. We knew it was going to have potential long-term effect on our financial stability. But the decision we made, and I give my board credit for this because I was very transparent. I told them this could cost us hundreds of millions of dollars. But they said, do what you need to do to take care of this region. And so we did it. And to me, those three things were the most important thing is just lean in and solve problems irrespective of whatever the consequences might be. The thing that I think I'm concerned about as we go forward, you can always look back and think, what could we have done better? And we, to be honest with you, we're still dealing with it. So we haven't done that yet. But we do it on an ongoing basis. But I think the things that I'm most worried about are look, the hospitals in a community are the bedrock of the health system in that community. No matter, it's true, they also are the most expensive part of the healthcare system, but they're also huge economic drivers in a community. They're huge job producers, and without them, you can't recruit and sustain doctors. So I think people need to stay very focused on the financial health of their hospitals, not because you want hospitals out there being profitable for the sake of being profitable, but if Tallahassee Memorial cannot capitalize, then all of a sudden you're going to fall behind on technology. You're going to fall behind on their ability to recruit and retain doctors. So you want your hospitals to be financially solvent and successful. And so I'm worried about that, because I think with all these uncertainties with volumes and whether they all come back, in my case, about 90% of our volumes are back. But when a rural health system loses 10% of their volume, that's a big miss. And so to me, that's the thing that I'm very concerned about. I'm really concerned about long haul. And I don't think we have an answer to that yet. I just think that we need data, we need studies, we need information. I think a lot of people, young people who have had COVID, didn't have symptoms. A lot of the patients we're seeing in our long haul clinic are young patients who don't know why they're having these symptoms. And that to me is the thing that I'm very concerned about, because we don't know what the long-term effects of this virus are. And third, I'm concerned about complacency. I'm worried with these strains that are emerging, particularly in India, the three variants that are in the virus that has the three variants. Who knows where that's headed? And I don't know if you're watching what's going on in India right now, but it is in Brazil. I mean, it is really still a major problem out there. So.
So for our virtual audience, if you'll just hang on, because we're going to go a few minutes over, because I have one more question for you, Alan, and that is, and you talked about it, you talked about your communication and speaking the truth to the public. So what do you think the solution, how can the federal government do a better job? Because we see Anthony Fauci on the news every night. It seems like every week he changes his opinion about one mask, two masks, mask all over our head, mask all over our body. And then we have President Biden. Some people believe that his continuing to wear a mask is undercutting the argument about the efficacy of the vaccine. What do you think government can do to do a better job of communicating to the public?
Well, the most important thing, and I know Melissa will agree with this, and Liz, we've all been through it. The most important thing you do during a disaster is communicate with the public. Consistency of information is important. Validity of information is even more important. I remember during Governor Bush's tenure, during all those disasters, he would ask a question and you'd give him an answer and he'd say, "How do you know that?" And he would keep at you until you could cite the source of the data, and then he'd call the source himself to validate it before he went on camera twice a day to talk to the public. Governor Jindal did the same thing. And so the worst thing you can do during a disaster is guess. Never guess. Tell what you know. But I think it's important to tell the public information can change based on what we learn. And it's not unreasonable to say something one day and a week later to say something different based on data that you've learned. But I think it's important to share the data. I think it's too many people have made the mistake of assuming the public isn't smart enough to figure this out. They are. But social media, there's an old saying, a lie gets halfway around the world before the truth gets its boots on. With social media, a lie gets to Pluto and back before the truth gets its boots on. And to me, that's been very damaging. So what I try to tell folks, and I'll tell you, I had an opportunity to speak to Governor DeSantis. I was with him somewhere back in December, and he was asking me a lot of very probing questions. And it was clear to me that he was reading the studies, reading the science, trying to make decisions that were evidence-based, popular or not. He was trying to get to what the data was showing, and he was digging in on the data. Governor Lee did the same thing in Virginia. But when you're in the middle of a pandemic or any kind of disaster, and you make emotional statements or statements that you don't have the data to support, that actually creates panic. I don't think you have to look any further than yesterday. I'm driving to Tallahassee and I can't find a gas station that has gas, because people just make statements without any data or facts, and the public doesn't know what to make of that. So they do what you would expect them to do. They protect themselves and their families. So the best advice I can give any leader in any kind of situation is get in front of the camera, share what you know, whether the public likes it or not. Share the facts, share the data from which you derived what you're saying, and tell the public this is certainly subject to change. And if it changes, we will tell you. I mentioned the hurricane. Everybody was preparing for it to hit Tampa until it wasn't. And the minute we found out it wasn't, I mean, Governor Bush got up and literally walked into the media room and told the public, get ready. It's coming into Port Charlotte. Now, everybody in Port Charlotte didn't scream and holler and say, why didn't you tell us this yesterday? They went and prepared themselves. And that's what leaders do. And I hope we just keep leaning on the data and the science, and then we cite it as we're talking to the public.
Well, and if you would come back up, not for a question, but for some of our speakers, we present a very special award. This is a bronze sculpture of an eagle made by a nationally recognized artist here in Tallahassee, Stanley Proctor. And we would love to give this to you. And thank you so much for being here today with us. So I think that's it for today. We've got a photographer here. So Economic Club monetizing. So if you're a Gator, it's $10 to have your picture with Alan. If you're anybody else, it's only $5. Thank you so much. And Chairman Bill Moore moves that we adjourn. Thank you for staying.